three kind of major messages, I guess, we'd like you to think about as we talk through today's presentation, my opening remarks. And then you heard from, again, from Julie Spillman from Southland County, Missouri, and how they're working through some of these issues in their local family drug court. But I want you to be thinking about perception and how that matters when, as a team or a collaborative, you're making decisions about reunification. This concept of having safe parents versus perfect parents, and understanding that this is really a process that we have to work through, both as a team and as the parents' journey in recovery. So we'll talk more about what those mean as we go through today's remarks. I'm going to pull the lens back just for a moment here and talk about families, kind of how they come into be under our supervision. And when we think about, as a nation, and this is a survey done from 2002 to 2007, and the numbers, we don't have any new numbers to think that things have gotten much better or much worse. Certainly not better. But about 8.3 million children today are going home to at least one parent or caregiver who is using or abusing drugs or alcohol. And the way to think about that is that that's about 3 children in every elementary school class across the United States of America, or 11% of the population. So clearly, there's no way that child welfare is planning to take all 8.3 million children into their care, and nor should they. But some of these children clearly do come into our care. And while the numbers of children entering foster care, and what you see in your screen here is the number of victims, has been going down, and if we back that data up into the early 2000s, you would see even a more dramatic decline. The national number of child victims has gone down considerably over the last 10 years, and so have the number of foster care entries. And this is a sustained or strategic initiative by the child welfare agencies across the country to really think about how do we put into place preventive services prior to removal, to eliminate the need for removal. And oftentimes with substance abusing families, what that means is to try to find a safe caregiver who can care for these children rather than removal. However, when we look at the number of children who are being removed, then we see since 1998 a steady increase in the number of children removed as a result of parental alcohol or drug use. Now, this increase is a result of 2 things, I think. Number one, and I think we can feel confident, this is a direct correlation to a better identification and better documentation of this issue of parental alcohol and drug use. As communities across the country over these last 10 years have really paid particular attention to this population, we've seen their ability to, number one, better identify families early on at removal, for instance, and also better able to document those cases in their state-administered child welfare information system. But in addition to that, as child welfare entries are going down, those that come into the system are oftentimes, or as you see here, having more likely to have an alcohol or a drug issue or substance use disorder, as well as other co-occurring issues. When we look at other prevalent studies, we see anywhere from 68%, and sometimes we hear as many 87% of families involved in the foster care system. And probably you in your communities, if you're in a room, you're looking around at each other, and you're probably agreeing more with these stats rather than the 30% number. You're probably thinking to yourself, yeah, we're somewhere between 60 and 80%. That's what we hear when we're out in communities working with courts across the country. So we're seeing that the number of kids that come into care are decreasing, and yet the number of families with substance abuse related issues are increasing. And those that end up with their parental rights terminated, the second highest reason is due to parental alcohol and drug abuse. Second only to neglect. And again, because of, we think, the low documentation of alcohol and drug use or parental substance abuse and the state-administered child welfare information systems, or fondly known to those of us, the child welfare SACWA systems, we can assume probably some of those numbers of neglect are also related to parental alcohol or drug abuse. So in other words, what we're seeing is that while numbers have decreased overall in just that, number one, the complexity of dealing with substance use disorders and the length of time we have in which to intervene with these families. And some of that is due to the Adoption Safe Families Act, which sets forth that we have about 15 months to intervene and to ensure that these families are moving, either move to make a permanency plan for the child, I should say. So with a child under 3, that can be much shorter than 15 months. So we have a very short time to intervene on a very complicated issue, such as substance use disorders and all the other factors that come along with these families. And so it's no wonder that these families often, in many cases, end up with their parental rights terminated. But one of the reasons for that is that there's this stigma about parents, oftentimes, that bring into the child welfare system and the courts, and that we see these parents as addicts, and that once an addict, they're always an addict, and that they don't really want to change. If they love their children more, they could get off drugs. And you know what, they need to hit rock bottom before we can get them into treatment. These kinds of thoughts, these kinds of statements, and I remember as a young social worker being out in the field, thinking that I could yell a parent into sobriety, and not really understand the complexities of addiction and recovery. And unfortunately, lots of us who go into child welfare and get our undergrad degrees in psychology or social work and a master's degree in social work, we get very little training on addiction. And so we're left with kind of with these perceptions. And it, we see the devastation it causes to children, and it just hardens us even more. One of the ways that we work with family drug courts and other types of collaboratives is we use this tool called the Collaborative Value Inventory. And it asks folks to respond to an anonymous survey. It's about 50 questions. And dealing with their perceptions around substance abuse and parenting abilities and even around reunification decisions and other types of interventions around child welfare, substance abuse in the courts. And I want to just point to a few examples of the survey results to give you an idea of what we mean about perceptions and why this is so important to understand in the family drug court arena, because you're making team decisions about visitation, about reunification, about whether you phase a parent up or you how you respond to certain behaviors. These are all decisions you make within collaborative. And it's important to understand your team members' perceptions or their values as you come into some of those discussions. So let me just give you a few examples of scores. And these examples that I'm going to share with you today, as you see down the right-hand side of your screen, is an N of 90. These are 90 family drug court professionals from about 20 different or 24 different, somewhere in that neighborhood, family drug courts across the country who are being brought together for a meeting. And prior to that meeting, we asked them to respond to the Collaborative Values Inventory. So these are not folks outside of, that don't have experience. So some of these folks are very experienced in the work that we all do. And so I just put that to kind of put these slides in context. We asked them about, one of these questions asked, people who have alcohol or other or people who abuse alcohol or other drugs have a disease for which they need treatment. As you see, again, almost everybody agrees with that statement. And there's a slight disagreement, but that's pretty clear. So if you had this team and you said, okay, great, most of us agree that addiction is a disease, that's a great place to start from. That's a foundation you all can work with and a conversation that you can have. We asked them again, people who are chemically dependent have a disease for which they need treatment, and 100% on this one. So when we said abuse versus dependent, you saw those numbers shift even further across, or more strongly into the agree category, and there's 0 that disagree. So again, talking about this N of 90 being all family drug courts, these are fairly educated folks in this arena who understand the difference between abuse and dependence. The next question, there's no way that a parent who uses alcohol or other drugs can be an effective parent. Now, notice this slide. Much more disagreement across the disciplines and across the participants. You have 10% of folks that absolutely strongly agree with this. There are about 30% who agree with this statement, while you're seeing nearly 70% or who disagree with this statement. Again, keep in mind that these are those questions that we do force decisions. There's no neutral, and you can nuance this question about a parent who uses alcohol or drugs. Again, the other thing I point out for this is our belief as a nation around alcohol versus drugs, and how that decision or how that belief system around the use of alcohol and sometimes even tobacco plays into our decision making. And in some cases, there's judges and attorneys and treatment providers who have been in AA for long periods of time and have different feelings than maybe someone who about alcohol than somebody who drinks alcohol occasionally. And so that's important for you to understand about your team members and where you land around alcohol. And many of us who work in child welfare for many, many years and have worked in family drug courts know that alcohol can cause just as much devastation as other drugs. But let's take note of that slide, because then when we move that question over and we say basically the same question, but we change a few words, there's no way that a parent who is chemically dependent on alcohol or other drugs can be an effective parent. Now we see nearly everyone agreeing with that statement, but again, 20% disagreeing. So the question is that because of alcohol, or is that because maybe they're dependent and they're in recovery? So again, these are nuanced. How we would use this particular instrument is that we use this tool prior to a site visit, and then we facilitate some discussion with your team around these types of responses so that we can get an understanding of where team members are coming from and help facilitate that conversation and put it on the table. Many of you have worked in these teams and these collaboratives, and you've discussed cases and trying to come to decisions about whether or not to increase visitation or even reunify or graduate a parent from your family drug courts. And you get stonewalled by one person on your team or two. And there's this big elephant in the room where they're having certain perceptions about families. They have certain underlying values or beliefs. And we want to help kind of flush that out and facilitate those types of discussions. So that's how we use this tool. A couple more, and I'm going to move on. But in our community, the judges and attorneys in the dependency court and the agencies delivering services to children and families are sometimes ineffective because they don't work together well enough when they're serving the same families. And again, we see a pretty divided response here. And again, these are from multiple courts across, but this would be important for you to know where your team members felt. And sometimes, you know, the judge may feel that everyone's working together really well, and there's that one team member or two team members or one agency that feels like they're just really not a part of it, and they're going to disagree with this statement. And just two more. The standard we use for deciding when to remove or reunify children with their parents is whether the parents are fully abstaining from the use of alcohol and other drugs. This is the question we asked you all on the polling question. And you'll see here a pretty even divide. A little bit stronger on the agree side. Yes, they need to be abstaining, but again, in this case, a little heavier in the disagree than you all responded today, with about 43% disagreeing with the statement, which is interesting considering they were all family drug court practitioners. And here's the last one that I'll share with you today. Some parents with problems with alcohol and other drugs will never succeed in treatment. And again, fairly split here, and having this discussion. Now, there's probably some rationality. Yeah, some parents will not succeed because addiction is very difficult to overcome. But then there's some folks that believe that addiction just isn't treatable, and that they haven't seen anyone recover, and they've seen high levels of relapse. And so they have a very negative outlook kind of on these families from the onset. That will inhibit your ability to kind of have discussions about families. And again, you know who these people are on your team. You know that you've had these discussions, and there's these underlying belief systems. And what we're encouraging you to do is understand that perception matters about these families, and that people bring in their own values and belief systems when they come to this work, whether it was from your own family of origin, whether it's from your training that you received as a professional. And in this collaborative, we all come from different training backgrounds. And we're not asking any of you to change your values or your belief systems. What we're asking you to do is to be okay with having a discussion, putting those on the table, and then work towards coming up with some shared principles that you can work from as a collaborative, so that you can then work best together to make important decisions about the children and families that you all serve in your family drug courts. And for the most part, I'm going to say that I think family drug courts do a good job of this. You know, if we look at data of the last 15 years, I think we've gotten even stronger over this. And I'll share just a couple of slides about this. When we look at studies from across the country, including one multi-site study, we see for the most part family drug courts have higher reunification rates than comparison groups. And then they also have less recurrence of child maltreatment. So we reunify children at higher rates typically. And in this case, for two of the grantee programs that we're sharing with you, the Regional Partnership Grant, which is about 24 family drug court sites, and children affected by methamphetamine, which was 12 family drug court sites. In that case, at the CAM grant, it's about a third of the recurrence of maltreatment that we see in the state contextual subgroup. When we look at reentry specifically, again, nearly a third reenter foster care versus comparison groups. So family drug courts, for the most part, you know, and study after study show that we do a better job of reunifying families, and then we keep those children out of the system in the future, for the most part. Some do reenter, of course, but not at the same rate as we're seeing in comparison to the national averages. So how are they doing that, I guess, is where we leave ourselves. And I want to talk through some of that now with what are these best practices that we're seeing in family drug courts that are leading us to these really positive outcomes around family reunification and then permanency, in other words, decreasing reentry. And I'll start with this, and we'll go briefly through this slide, but we often talk about these 6 common ingredients in family drug courts, and some of these, I think all of these pertain to reunification, because the first ingredient we talk about is there needs to be a way in your family drug courts that you're systematically identifying families early on. So that looks different in family drug courts and communities across the country, but some way that as soon as removal, soon after removal as possible, or even prior to removal, you're identifying these families as potentially being eligible for your family drug court, and that they're getting early access to assessment and to treatment services. That it's not a referral and go down the street, but it's a memorandum of understanding, it's some kind of priority access to these assessments, to these treatments for these sets of families, so that they're not on long waiting lists. Because clearly, we're not able to identify them early on, which often happens with these families. We don't think substance use is the primary issue. It's physical abuse, or it's domestic violence, or it's a messy house. And 6 months down the road, we realize, oh, you know what, this is really related to a substance use disorder or co-occurring mental health disorder, and we didn't identify that early enough. And now we're really pressing at that ABSTA time clock. So that systematic way to identify families early and get them right into an assessment and treatment is critical for timely reunification. And of course, the increased judicial oversight in the first phase of family drug courts, we really encourage weekly or biweekly court sessions. This is how you're making sure that your treatment plans are appropriate, that parents are getting engaged in the services, that you're working through some of those barriers that families in early recovery or early abstinence are struggling with, and that the judicial oversight and the team coming together on a weekly or biweekly basis are able to make those adjustments early on to that case plan, to that treatment plan, to meet the needs of that particular parent or family. There needs to be some type of increased case management of the recovery services and compliance, more than just the social worker who has 40 kids on their caseload, who has there needs to be whether it's a dedicated social worker unit who has reduced caseloads, who manages just the family drug court, or a recovery support specialist who's added to we want to be in those weekly or bi-weekly meetings. We want to be responding really timely to behaviors, both positive and negative, and thinking about from the get-go, what's this plan or what's the goal of this parent? Is there a goal reunification? What is that going to look like for this parent? And are they responding, are they behaving in a way that is moving them towards their goal? And if not, how do you respond to that behavior and maybe adjust treatment plans or we help to use other activities that re-engage that parent to help them with their own goals. And of course, all this has to happen in a collaborative way with judicial leadership, but these responses to behavior, this increased case management, all these things also need to happen beyond the court and in the other systems that partner together. The second thing you have to have, as well as that strong family drug court kind of process, is that you need to be referring your parents to effective substance abuse treatment, and we would encourage evidence-based substance abuse treatment. And we're not going to spend a lot of time on this subject today, but we've done at least one webinar on this topic in the past. We'd encourage you can go to our blog, which is the website here, and take a look at that. You can go to our website and you can view that webinar on how do you know that you're, number one, if you're purchasing treatment, you're purchasing effective or quality substance use treatment. And even if you're not purchasing it directly, you're referring your parents to treatment, how are you ensuring it's effective? And some of these bullets talk about what those look like. That it needs to be readily available. You need to have engagement strategies. It should meet their individual needs. It should be addressing co-occurring conditions. They should be assisting with the monitoring, etc. It should be curriculum-based for many, and not just process-based. I'm going to talk a little bit more about ways or resources you can look at for effective treatment. But one of the most important things that you're going to want to do with these families is engage them in treatment. And I'll show you some data in a minute to talk about the importance of engaging parents in treatment. And the best way to do that in a family drug court, we now have the research to show that, is the use of a recovery support specialist. And this looks different in different places. Sometimes they're liaisons, sometimes they're treatment brokers. They know where the treatment is in the community, and they're helping parents get to that appropriate treatment. Sometimes they're advisors also to the community, to your team. These are folks who that themselves are in recovery, but they've also received specialized training to become a recovery support specialist. So in some ways it's a peer mentor, but it's a peer mentor as a professional. These are paid staff who have specialized training in recovery support. And when you add this type of recovery coach or recovery support specialist to a family drug court, then what you see here is, and I will go through all of these, but when you go from no support strategy whatsoever, these programs are keeping parents in treatment about 100 days, which is fine, which is good, but we're keeping them in double that amount of time when you add in the recovery coach and the case management. And the longer you keep parents in treatment, the more likely they are to reunify. Substance use treatment completion rates, again, we see dramatic increases. I jumped there. So no. We see dramatic increases in treatment completion rates when you add this recovery coach model to your case management that you have in your family drug court. 20%, nearly 20% higher for those programs that have no parent support strategy. Again, when you have parents who complete treatment, they're much more likely to reunify than those that don't. We also want treatment to be comprehensive. So once you actually get them in there, you got to keep them in there, and you want to make sure your treatment is comprehensive. You want it to be evidence-based, I spoke about before. There's lots of places to find out if your treatment providers are providing evidence-based treatment, and we can provide those links to you. ABSTA has some great resources on that. Here's just an example of evidence-based programs for trauma survivors. So there's a very just trauma-focused treatment for substance abuse, and we see a lot of folks using the Atrium model. We see a lot of folks using TAMAR, and also Seeking Safety is a really popular one for family drug courts and adult drug courts. So it's okay to ask your treatment providers, hey, do you have a recovery coach you're going to sign for our family drug court families, or what type of treatment model are you using? And ask them these questions. It's okay to ask those questions. You can also go here to the National Institute on Drug Abuse to look at the 13 principles of effective treatment. And I'll end there with that. So we know that we need effective treatment for these families to be successful. That's number one. We also think that your family treatment needs that your substance treatment needs to be family-centered, because after all, this is a family disease, and recovery and well-being occurs in the context of family. So thinking about rethinking in some ways our approach, and again, sometimes this is more difficult for our parallel family drug court, those that, in some ways, whether you're in child welfare and you refer to the family drug court, you think, I'm going to send this parent off to the family drug court, and it's a parallel docket in which they go to court every other week, and they see the judge, and I get a report twice a month or once a month, and it's kind of like this black box. They go do their thing, I'm going to manage my cases, and I'll deal with the child and the larger case plan, and when that parent's well or in recovery, then great. I'll check that box so we can start talking about reunification. We'd like to challenge that thought and think about, from the get-go being family-centered as possible, and thinking about how we have from the get-go family team meetings and assessment tools that look at the whole family and their functioning, and how we're having parent-child time or family time as much as possible from the get-go, or as early on as safe to do so. And it's because of this child-parent relationship, and it's just as important that the parent understands their children's needs, and that they're understanding these needs while they're in treatment, so they have the support of the treatment agencies to deal with some of these things. We're going to talk about some parents, again, when they're isolated, their treatment is isolated from the child's treatment, then they're not able to process sometimes these special needs these children often have that are involved in family drug courts. Some of the children that you're working with have specialized education needs. They may have specialized medical needs. They may have developmental delays or social emotional problems that will need to be ongoing care, even beyond reunification, or even to think about reunification. And having that parent begin to understand those needs and to participate in those things, even while they're in treatment, is really a good practice, and that they're able, and that the treatment provider knows about those needs, knows about those meetings that are coming up, those educational, individual education meetings and medical appointments, so they can then be a support to that parent as they begin to process through some of those feelings that often come with that of guilt and other types of feelings. So helping parents be a part of that, and treatment supporting child welfare and the children's treatment providers in that process. So working together for this goal. Here's some data. I spoke about this. Women who participate in programs that included high level of family and children's services and employment and education services are twice as likely to reunify with their children. This study found. The second is retention and completion of treatment has been found to be the strongest predictors of reunification for children with substance abusing parents. 2 studies there found that. So I think we can conclude that substance abuse treatment services that include children in treatment or include high level of children and family services, and keeping parents in treatment and completion of treatment will lead to improved outcomes for the parent, which can also lead to improved outcomes for the child, meaning reunification oftentimes. Another really important practice to be thinking about is be supporting your decision around reunification and timing is an evidence-based parenting program, and one that involves not just the parent going to some didactic type of educational class, but one in which the whole family comes together. And we've seen tremendous results with family drug courts using these types of models. Again, we've done a whole webinar just on this topic. You can go to our archive or go to the website and download that webinar and listen back to it. But the most effective parenting programs are those in which parents and children come together, and children are learning about a similar topic as their parents in a age-appropriate way, and they're coming back together as a family, and then parents need to be able to practice those skills with those children. So having just 1 hour of visitation and supervised in a social service office is not going to give that parent the best opportunity to practice the new skills that they're learning in your parenting program that you're probably spending lots of money on. So understanding that when you're ready to move your parents into these high-quality parenting programs, that you also want to make sure that they have enough time with their children to begin practicing the skills that they're learning. And I won't get into selecting a parenting program. I'll just say that the most important here is to think about how you match your target population. Don't choose if you only are a 0 to 3 court, then make sure the parenting program you choose targets 0 to 3 children. And understand that there are costs to these evidence-based programs, and you need to really think about how you're going to train your staff and get parents to these programs and children to these programs if they're in foster care. So there's lots of considerations, and again, if you look at our webinar on the topic, it'll be helpful. So now you engage parents in your program early on. You provided early access to treatment. They've gotten quality treatment. You've engaged them using recovery support. They're working a treatment plan. They're understanding their children's needs. Treatment is supporting the children's treatment plan, as well as the children's treatment is supporting the parents' recovery. And now they're in these parenting groups, and they're practicing their parenting skills. Parents are now getting ready for unification. One strategy that we're seeing across the country that's been very effective in this support is the consideration of a recovery, a reunification support group, I should say. And these start sometimes as parents begin their unsupervised or overnight visitations, sometimes prior to reunification and after reunification, in this case 3 months post-reunification. They're staffed in some cases by treatment providers, other times by recovery support specialists or case managers. They're staffed in different ways. But the idea of it is this is a safe place for parents who are getting near reunification, who've had their children out of their home now for several months, who maybe never have parented sober before in their lives, to have a safe place to come and process some of those fears, some of those feelings with other parents and with a neutral party or a facilitator who can help support and process those feelings and with these parents. And we've seen this be not only effective in engaging parents or retaining parents in that reunification process, but post-reunification as well. Some of you have told us that you'll see families, once they reunify with children, they tend to drop out of your programs, and having this type of support group sometimes keeps them engaged, helps retain those parents. Because again, it's a pleasure to talk about what it's like now to have 3 children back in the home after they've had no children for so long, and how they continue to work on the recovery while also managing the household now with multiple children in their home and all the other demands they have on them. So there's one strategy for you to consider. And then, of course, you want ongoing and aftercare support for your family. These are things that you all do very well and well-functioning in the drug court. The other part that I may have skipped over, but that I may have emphasized, and I just want to hit it again, is the importance of visitation as early as they can do and as often as possible, so that these parents, not only are practicing their skills and practicing being a sober parent with their children, but what the important thing of that is that it also gives you, as the family drug court professionals, an opportunity to see what that looks like, to see how the child reacts after a visit or during a visit, see how that parent is progressing with their parenting skills, and so that you can make better informed decisions. With the parent only having a week, an hour-a-week visit supervised, and then trying to make a decision about overnight or trial reunification, that's a big jump. And so being able to move those visitations up more frequently, more often, gives you more time to look at that parent in the context of doing the parenting sober. And also post-reunification, being sure that you are not waiting so long to reunify that your family in compliance. And, she starts out, she misses her first court appearance, she's not calling her case manager, she's testing positive, she's not in treatment yet, she's really not even engaging in visitation. But then soon after you see, well, okay, I'll come to court, and yeah, I guess I'll call my case manager. And after a couple of court appearances, because she finally got a visit, she's saying, okay, I'll get into treatment. And so you see that she gets into treatment, and now she begins really getting engaged. And her visits are happening regularly. She's attending all of those. She's testing negative. She's calling her case manager. She's attending all of her court appearances. Now she's starting parenting programs. And she's totally in compliance with the phases of your family drug court. Then she starts a job, and she's still in treatment, but she missed the test, and she forgot to call her case manager, but she showed up in court, and now you're making a decision about what to do about that session. And sometimes in our biweekly report, all that we have is this 1 week or this biweekly report. And if we look at that in isolation, totally from everything else, then all that we see really is a mom who is not doing well. We see a mom who's missing drug testing, not calling her case manager, but we don't see it in a larger context of this mom who's been working in this program over time and changes in behavior. So of course we want to ask the question, why did this happen? What happened here? And understand it better. But we want to understand it in the context of the larger schema. And all too often, we spend a lot of time processing or staffing these cases, but we're only focused on this week and not on the full life of this case and where this mother has come from, just the full life changes she's made in her progress, in her treatment program. And so there's a way that you can look at this in context that I think you're often able to make some better decisions. Because that's the two, really, are we thinking about parents in a safe way? Are they able to safely maintain these children in their home? Are they able to safely visit with their children? Are they able to safely have overnight? Are they able to safely have a trial reunification? Or are we waiting until these are perfect parents? And, speaking as a father of a young child, I can tell you, probably none of us are perfect, but we hope to all be safe with our children. And I think that's what we want to ask for with our parents as well. All right, so lots for you to think about there. I want to move now to another polling question before I bring Julie on to talk about how they're kind of working through this in a concrete way. But let's go ahead and launch this polling question. And we're going to ask you another one of these values questions. In preparing families for reunification, our family drug court is experiencing the greatest challenges in implementing the following: ensuring quality parent-child contact, cross-distance communication, how do you communicate across your programs, implementing family group meetings, evidence-based services such as parenting or therapy or treatment, or implementing a recovery or reunification support group. So let's go to launch that, and we'll give you a few seconds to respond to that. So it looks like really two areas in which you're seeing some challenges. One is really communicating effectively across systems. So that might mean getting timely information from the treatment provider around what's happening with this parent, or this may be getting information about where the child's at. That could mean a variation of things. And also the second one, about a third of you are really struggling with trying to implement or thinking about implementing a reunification support group. And some around ensuring quality parent-child contact, but that seems to be a low number of you. So again, thank you for participating in that poll. And with that, I'm really pleased now to let you hear from Julie Spielman, who's going to talk to you a little bit about the experience that they're having there in Dunklin, Missouri. Julie, welcome.
Thank you. I appreciate Children and Families Futures asking me to be part of the webinar today, and hopefully sharing our court's experiences and some of our practices will be of value to all of you, and kind of explaining to you how we've worked through some of the issues that Phil has already brought up. So if there's any questions that don't get answered, I think there's some contact information coming up, and I'd be more than happy to answer any emails or that kind of after the webinar. So with that, okay, thank you. One of the things we address with readiness for reunification is visitation, and we've kind of looked at it as a good tool in reunification readiness and being able to observe some of the visits. So we've restructured our whole program to work around visitation. So I wanted to talk a little bit about visitation first. As I think Phil already said, it's a great time to strengthen the parent-child relationships and to help with that bond. And also, it's a good time for us to observe what's going on and how the relationship between the children and the parents is going. And one of the important things that our court always tries to stress is that visitation should never be used as a sanction or a punishment. I mean, taking away visitation should never be used as a sanction or a punishment. We actually don't use any sanctions at all in our family treatment court. We try to use treatment responses instead of sanctions. So we may, now if there's a safety issue, the visitations may go back to being supervised, but we try to always make sure we never take away visits as a reaction to anything that's happened other than when there's safety concerns involved. So, so one of the things that we had issues with was time for visitations. Our visitations at the Children's Division in the meeting rooms were limited because they've got plenty of other families they've got to arrange visits for besides just our family treatment court clients. So we have been able to make a visitation room as part of our CAM grant at our office so that we can add a few extra visitations in. And that lets us have our parent aid here as far as coaching parents in the supportive and structured environment. We can have our parent aid present for some of the extra visits and work with them. And then we say we try to increase visitation by expanding other opportunities like doctor's appointments for the children, school events for the kids. We try to find other places they can go in the community to do visits, like the parks or different things like that, instead of just having visits in the office. And then we make sure, of course, that the decisions to have the supervised interactions are based on safety concerns, like I said, and not as a sanction. And then, like I said, we do try to have the foster parents involved in the visits. We help parents plan the visits ahead of time. We have a service coordinator who helps with that. And then, like I said, the community settings, I think I said some of the things on this slide already, and limit the children's exposure just to the adults they're comfortable with. We try not to have our parents bring other people along to the visits if it's not someone the child's already comfortable with. So. Okay, I think the next slide just shows our a little bit about our community, about our county. Because you can see we have a pretty small, it's a large area and a small population. It's a very rural area, so you have an idea of where we're coming from. And then we are a parallel court. I know that Phil talked about the two different kinds of courts. We have our family dependency court who overlooks the case when it's first open, and then they control the visits all along. And then as soon as they are referred to us, then they come to family treatment court weekly and just go to the family dependency court on the scheduled hearings that are required in the family dependency court. Our treatment court was established in 2005, so we've had it for quite a while. We went through the planning initiative in 2005 and then started our court immediately after we finished. In our county, just so you have a little idea of our background, the total number of children in care from October 12th to September of 2013 was 131. The removals due to caretaker, drug, or alcohol abuse was 35, and all removals that are due to substance abuse issues are referred to our family treatment court. We do have a children affected by methamphetamine grant, and that has really helped us the last couple of years. Like I said, it's let us build a family-friendly area in our court, in our treatment center, and our courts offices are all in the same area, and now we have the visitation room as well. and it's helped us develop some extra services such as nurturing parenting and getting involved with some of the community resources like Parents as Teachers. So that's been very helpful. So our structure when we started it, we started our adult drug courts in 2000. So we'd already had that going for about 5 years. So we thought, well, we'll just do the same thing but make it family courts. And that didn't really work out that well. We started with 3 active treatment phases, and then we had 1 aftercare phase when they were finished. Each phase had specific requirements that had to be met to advance to the next phase. The phase requirements were the same for each participant. That phase 1 was a minimum of 12 weeks, and you had to finish, step 6 in MRT, and everything was exactly the same for everybody to move to phase 2, and then each phase from there on out. And then the progress would be reported to the family court judge when they had their scheduled hearings. The visitation was not determined by the family treatment court. It was determined by the family dependency judge. So it was kind of difficult because we thought, we had a better understanding of what was going on, and then we would go over there and report back to the family dependency court judge who had the ultimate decision but maybe didn't have as much contact with it. What we observed from that was that, most importantly, the parents really did not care whether they were in phase 1, phase 2, or phase 3. They cared about their visitation status, when they would be reunified, and when their case would be closed. And the family court, the family dependency court, when we would go over there and report, well, they're in phase 2, they can't advance until they finish this, this, or this, they really didn't care what phase the client was in. What the family dependency court cared about was sobriety and the readiness, were they ready to be reunified? So the readiness for reunification wasn't based on phases. It was based more on sobriety, safe housing, whether the issues that resulted in the removal were remedied. And so often there was just some disagreement among our team when we reported back to the family dependency court judge. The treatment provider might have been saying, they're just really not ready to get the kids back yet, but juvenile office and children's division, they said, well, all the issues that we removed the kids for have been addressed. We're ready to give them back. And so there really wasn't one team report going over to the family dependency court. So what we decided to do about that was, we can go to the next slide. What the results that it was producing was families who were maintaining families who were maintaining sobriety and had fewer issues to resolve were being reunified earlier in the process, but they still had the minimum time phase left to complete or some standard requirements left to move up a phase. So once reunified, the participants knew that failing to attend treatment court wasn't going to result in removal as long as they were testing clean and they were maintaining a safe home environment. So eventually, if the children were returned and reunified early and they were still, maybe those clients were still in phase 1 or phase 2, they weren't going to complete family treatment court. They would stop coming because they knew as long as they were maintaining a safe home and they weren't testing positive, that the kids wouldn't result in a removal if they just stopped coming to family treatment court. So we were seeing unsuccessful discharges from family treatment court even though the goal of reunification had been met. So we learned from that, first of all, that we needed to find a better way to motivate participants through the phases of the program. Because, like I said, the only questions they had was, when will my kids come home, not when am I going to get a piece of paper that says I moved to phase 2. So we knew that we needed a better way to motivate them. We also needed a better way to keep participants engaged at the end of the program once the children had been returned. We needed better collaboration with the family dependency court so that we were all on the same page. And we knew that we needed to have the whole treatment court team on the same page and in agreement with what our recommendation was going to be before we went over to the family dependency court hearings. How we approached the problem was we wanted input from both sides. We didn't want to spin our wheels and just talk amongst ourselves and decide to try something different without input from everybody. So we invited all of the family dependency court judge, all of the attorneys that are involved in family dependency court that serve either as GALs or attorneys for the parents, and we asked everybody for feedback. And we also had the juvenile office and the children's division workers and our treatment staff. And we asked everybody what they thought the strengths were of our program and what they thought the weaknesses were. And what we learned at that meeting was, first, that not everybody had an accurate understanding of what the Family Treatment Court did. There were a lot of misconceptions among the people who came to the meeting. But also, we learned that everyone wanted to make the system as cohesive as possible for the families involved. So we knew that with talking with everybody, we decided we need to make the Family Treatment Court timeframes match the Family Dependency Court timeframes so that it made sense both to the families and the practitioners. So we needed better communication between the Family Treatment Court and the Family Court. So as a result of that meeting, we decided there would be no more Phase 1, 2, 3, and 4, and Family Dependency Treatment Court would now be based on visitation status. It made more sense to everybody that way. So when you first come in, for the most part, people would come in and have unsupervised visits. So the next stage of the program would be supervised visits, unsupervised visits, and trial home visits. And then the case would be closed at the same time graduation occurs from Family Treatment Court. And so we developed a goal sheet to get through those stages. So when someone is referred to Family Treatment Court and they before they start their treatment plan, the participant meets with our service coordinator, with their children's division worker, with the juvenile office liaison, and with their treatment provider, and then later on also the parent aide, but in the beginning just that group. And each person at the table, including the participant, sits down and says, what do we think needs to happen before we get to unsupervised visits? And it might be that they need a safe place to have the unsupervised visits. It might be that we want to make sure they're getting on the van and coming to treatment, and they're participating in groups, and they're presenting steps. Children's Division may have some concerns about something with that particular child and say, well, we need to address this issue before we can do unsupervised visits. So everybody comes to an agreement. We develop a goal sheet, and everybody signs the sheet. And then when all those goals are met, the treatment court requests the hearing in front of the Family Dependency Court judge, and we go over there and say, this participant has reached all the goals that we set out for them to have unsupervised visits. So then once those are granted, everybody meets again, and this time we usually include the parent aide as well. And they list the goals that they think need to happen before a trial home visit starts. And it may be different for each person. Some people, they may say, this person really has financial issues, and before we start the trial home visit, we should try to work on employment and make sure that they've got a stable home plan and a place that they can afford, and that we won't be moving again in 30 days. Or there might be somebody who, it may be a family, and maybe they don't need to look for employment. So each goal sheet for each person going to each step could be totally different. So once those goals are met, then the last one is developed and signed, outlining the goals that have to be met in order to have the Family Dependency Court case closed. And I think the next slide just kind of shows what they have on there. So that's what each little goal sheet, and there would be a list of 4 or 5 goals that they need to accomplish, and then everybody signs those goals. So results after we did this is that we no longer had a one-size-fits-all program. Participants were engaged in designing their own treatment court program, which helped with retention and treatment. They felt like they had a say in what was happening, and they felt like they had a say in what they needed to do and what services they needed before they could go to each different step. And I think that made as big a difference as anything, just giving them a voice in the process. We also learned that pairing the progress with visitation definitely increased the motivation of the participants. Instead of saying, you've got to get this, this, and this done, and we'll move you to Phase 2 or we'll move you to Phase 3, when they had a list of things to get done before they could get unsupervised visits or before the kids could come home, it motivated them in a completely different way to get things finished. Coordinating the completion of the Family Treatment Court program and graduation with closing of the Family Dependency Court case eliminated the problem we were seeing with participants who would have the children reunified and then fail to complete Family Treatment Court. When they knew well, as soon as I get these things done, my case will be completely closed and I graduate. It was a lot more of a motivation to get through those final months of the program. Because it wasn't just treatment court graduation, it was also having their family dependency court case closed for good. So that made a big difference in our successful completion rate. And it gave us those extra months once the kids were returned to keep working with them and working with the parent aides and provide that support that Phil talked about after the children were reunified. We were missing that before when they would just have the children home and then stop coming. So that gave us a lot more time to do that. Meeting to develop the goal sheets increased collaboration among the team members and assured that all the agencies and participants were in agreement before attending the family court hearings. So that was good too. And made a big difference with how we presented our family treatment court reports in the family dependency court because we were all in agreement before we went over there and met. So we also have some extra supportive services that help enhance the visitation. So we have a service coordinator as a result of our CAM funding, and we're looking for a way to keep her. And she can assist in arranging the visits. We also have a parent aide that can be present if requested either by the parent. A lot of times we have parents who say, you know, could Miss Terry come in to my visit this week and help me work on this or help me work on that? And they'll talk about maybe what issues they're having between the parent and the child, and they can work with them there during the visitation. And then, as I mentioned earlier, we now have the child-friendly space for them to meet. It's a lot more comfortable. It looks kind of like a living room instead of just a empty room with a box of toys. So we think that helps the quality of the visits that our parents are having. So post-reunification support, like I said, now that we've rearranged our whole structure, we've got a better opportunity to provide support post-reunification. So we try to have a weekly group. Sometimes it's biweekly with our parent aide in charge of the group that day. And we encourage the children to attend the group. A lot of times sometimes they just do fun things like teach them how to make different crafts or teach them how to cook some child-friendly stuff with their kids. We also use the nurturing parenting curriculum for a more structured group, but sometimes, occasionally, maybe once a month, we try to just let the parents and the kids do something fun together too, post-reunification. So it kind of helps them, just helps us observe how they are in a more relaxed setting around the kids. And then, of course, besides the groups, we have the in-home parent aid services available post-reunification as well. Not just before we try not to just cut off the parent aid services when we feel like they're ready to go home. And a lot of times new issues come up once they're reunified. So we try to extend the in-home parent aid services post-reunification as well. We also continue to make referrals to family counseling as needed. We help with assistance in maintaining safe and stable housing. We may help them with a deposit or with rent 1 month just to kind of keep them in that safe and stable housing if they need it. We continue both substance abuse counseling and mental health counseling post-reunification, and we can still help with employment and education assistance. So again, some of the challenges with the parallel court model is who controls the visitation status. The treatment court has more knowledge of the participant's readiness, but then the family court judge has the final say on visitation, and we really struggled with that in the beginning. Sometimes we'd have, treatment saying, if you send the kids home right now, we're going to lose touch with them. They're going to go right, they're in a good place right now, but we're not quite ready. But the family dependency court was looking at, well, it's safe, it's, clean. They've changed the reasons, changed all the issues that the kids were removed in the first place. I can't just wait because one person says they're not quite ready yet. But we've really, I think, improved on that. So working together a little bit more and more collaboration has really helped with that challenge. Occasionally, the parents or the participants will try to work one court against the other. They may go to family dependency court and say, well, those family treatment court people are kind of unreasonable. I missed, but I had to work, or, I know I haven't been there in a week, but I had this going on. It wasn't my fault. So So again, more communication between the two courts has helped take care of that problem. The Family Dependency Court has a better understanding of what we're doing now and trusts us a little bit more. In fact, in a lot of cases now, he'll just make the Family Dependency Court judge will just make a standing order that says visitations can move to unsupervised, or the trial home visit can start at the discretion of the Family Treatment Court. So we've communicated enough now and have a good enough understanding of who's doing what, that now that they will occasionally just give us discretion to go ahead and change the visit status for the better. So the last one is that it's complicated for parents to understand in a parallel court model sometimes. They don't understand why, if I'm going in front of this judge once a week and I talk to these people every day once a week, why do I have to go over to this other court every couple of months and report over there? Why isn't this court just in charge? So I think a parallel court sometimes can be confusing for the participants. Lessons learned, and I see some questions that are coming up on the side about cost savings and some questions about time to reunification and whether or not we're doing better. And I will, we actually have an evaluation that's ongoing, and as soon as we get the final draft of that, if anybody would like the evaluation, if they want to email me, I'd be happy to send it out. And that'll come up in our next steps too. But lessons learned, the main lesson I think we learned is that readiness for reunification may mean different things for each family, beyond, of course, the basics of safety and sobriety, which have to be there. And I think that, I think Phil touched upon it a little bit with safety versus perfection. We're not looking for the perfect parent. We're trying to make things safe, and but beyond that, it might be different, like I said, for each family. And so we try to look at each group individually. And even with sobriety, we look at it at an individual level. I know one of the questions that somebody sent in was, what if you have a parent that's completed treatment, they're doing really well, and then they relapse? Do you have to, are they ready for reunification? I think that depends on the circumstances of the relapse. You might have, did they relapse with the kids present at home, or were the kids with the other parent for the weekend and they relapsed and they came in right away on Monday and said, I'm sorry, I messed up over the weekend, here's what happened? Or, did they use it the kids at home and try to hide it? So I think even with issues like that, it's an individual situation, and you have to assess each family individually. So we don't have, and another question I know people had asked too was, is there a tool that assesses readiness? And I don't think we have that. I don't know of one, but I don't know if we would be comfortable using just sort of an assessment type tool instead of using our team. We kind of look at our team as the tool to assess readiness for reunification. Each team member kind of brings their own area of expertise, and when we discuss each family individually, we usually can come to a conclusion through the team collaboration. So that's kind of what we use as our tool. The other lessons are that, well, like I said, the treatment court team has to work together to determine the readiness of each family. So that kind of ran into that one. But also, the big lesson we learned is that it works a lot better when the family has input on the process and the determination of readiness. I mean, we've had people that we've been ready to go ahead and start the trial home visit, and the parent said, I'm not ready yet. I'd like to do this first, or I'd like to work with, maybe do an overnight visit and have the parent aide come for a while and observe. So we've learned to try to listen to the family more instead of just saying, well, check this off the list, check this off the list, they're ready, let's go ahead and send the kids home. One of the most important parts has been letting the parents and the family have input in the determination of readiness. So my last one, I think, is the next steps and how we want to improve our program. We want to analyze some of the outcomes that we've had and compare since we've made these changes and see what the differences are before, when we had our old structure and our new structure. We've looked at some of our numbers, and we're pretty happy with we've looked at our outcomes since 2008. From all the exits we've had, either successful or unsuccessful from 2008, we've only had 4 families where the children have been re-removed and returned to foster care. So we're pretty excited about those numbers, but we'd like to look at some other issues, and I think we are doing that in our evaluation with time to reunification, time that it takes from the removal to getting engaged in treatment, and a few other issues like that, and try to see if we've improved with our new system. We are also looking at increasing family support by adding recovery support specialists and peer mentors. We've had graduates that are kind of fulfilling that role on a volunteer basis at the moment, but we did receive state funding this year, so hopefully we'll be able to have some paid support specialists and peer mentors. It'll probably be those same alumni members. They're going through the classes right now to be certified, so we're hoping that will also improve our outcomes. And we also are excited about starting to address parent and child trauma by introducing the Seeking Safety curriculum. We just went through a trauma walkthrough earlier, actually last month, and they've made recommendations for us to start addressing some of the trauma issues. So those are the ways that we are looking at improving our program.
Excellent. Thank you so much, Julie. I really appreciate your comments and reflections, and I find it remarkable how much work you all do in your rural jurisdiction. We often hear so many of the barriers that rural courts face, and your guys' ability to mobilize these resources is really impressive. And I think it offers kind of an exciting way to think about this phased kind of approach to family drug courts. As you started off, Julie, too, with the thought about how we structure our phases, and it is a recommended best practice. It often comes, again, from that early adult drug court literature, but there's no reason to say that phasing can't be renamed, and essentially that's what you've done, and you've allowed these parents to use self-determination, self-actualization to kind of say, here's the goals that we need to do in order to move to that next step of reunifying with my children, which are, as you've shown, your increased contact through, increased visitation. So I think it's really great. There were a few questions. You addressed several of the questions that come in. I'm going to encourage participants to continue to submit questions for Julie or myself. If we're not able to answer those right now, we will post questions and responses to the questions on our blog following the webinar. I want to just follow up on the question that Julie responded to just a moment ago around the tool. And this is a question that here at the National Center we've received for more than a decade. It's kind of a question that people often ask about what's the tool to use. There's one of the earlier publications that's available on our website, and we'll post a link to it to our blog as well, as a screening and assessment for family engagement and recovery. Family engagement, retention, and recovery, or SAFER. And in that publication, it talks about looking at tools, and in the appendices, it provides examples of many, many tools that not only screen for both the substance abuse side of things and the child welfare side of things, looking at safety, risk, strengths and needs, case planning tools, as well as reunification or permanency tools. Some of the tools highlighted in there are things like the structured decision-making tool, which does have a reunification assessment tool. Many of the child welfare agencies across the country are using that tool. There's tools such as the North Carolina Family Assessment Scale, or the NCFAS, that lots of our grantees that we see family drug courts using, that has a reunification readiness scale actually on the tool. But as Julie said, and I think SAFER concludes, is that it's not the tool, it's the team. And what we mean by that is not just our perceptions or, gosh, yeah, we think this mom's ready, but it's about our collective understanding, and that the child welfare may use FDM, and that they show that they're ready for reunification, and that substance abuse treatment is also looking at a treatment completion plan and their progress in treatment and how they're working, and bringing that tool and that understanding, interpretation of the assessment to the team. And there may be a recovery support specialist who's doing has an assessment. And so you have not one tool, but now you have multiple tools from different perspectives, as well as clinical insight from these professionals coming together to make individual assessments about readiness on individual families. So Julie said, it's the team, not the tool. But I would point you to safer, at least for a start, to look more into that. The other question I wanted to just talk about and follow up on again, I think Julie may have talked a little bit about this, but is about child readiness in reunification. And clearly as the child gets older, even as a young child, these are all individual case decisions that you have to think about, about the child being ready, and as the child gets older, they will have a stronger voice in that decision-making process and being part of the team, maybe, and being ready for reunification. And so those are individual decisions you have to make. And Julie, did you want to speak at all to child readiness for reunification?
Sure. We've actually had that come up for the first time just recently, where we've had a child that she has some special needs and she's not quite ready to go. Mom's doing great. She's got a job. She's been clean for months now. She's got her other child back, but this child's not ready to come home yet. And so we're actually kind of working through this for the first time in a while, where the children were really just, this particular child's not quite ready to be reunified. And what we've really relied on our treatment counselor and that parent counselor to kind of help her through the idea that, she's doing great, it's nothing she's doing, but we need to address that child's issues before we can bring her home. And I think it's just a matter of reassuring her that she's still, as a parent, she's doing everything we're asking her to do. She's doing great, but we want to make sure all that child's issues are addressed and make sure that we have everything ready when she comes home. So I think it's just kind of a matter of making sure everybody on your team is sympathetic to that parent and making sure they understand that they may be doing everything right, but there's just some things that need to be addressed still that they may not even have control over, that parent might not have control over. So.
Yeah, there are cases, I would say, in which, and this is one of the ways I think, again, the family drug courts are particularly effective, in which maybe the parent does do quote-unquote everything they're supposed to be doing, or even working, into recovery, but there may be cases in which the children have such specialized needs, in which maybe even if the parent is abstaining or from drugs and alcohol, and even in recovery, they may not be able to care for that child, and they may not, and they may even come to that decision themselves, and so they may be part of the permanency planning of that child, and even, and relinquishing their rights to allow that child to live somewhere else. So again, it's not always about reunification. It's sometimes this path and journey of recovery and working with these parents
Right.
through the process may help them kind of come to a different decision themselves even. So anyhow, Julie, I think you had a couple other questions there. Do you want to go ahead and just respond to those?
Yes, the first one was, let me find it. The first one was the two-parent question. What you do when you have two parents participating in family dependency court. We try to treat them as a family, but I know sometimes, and we have a goal sheet for the family. Now, sometimes we do have a couple right now who they're not really progressing at the same rate, so we are working with them as individuals. And we've had it happen a few times. If it is a family and they're working together as a family unit and they're progressing the same, then we just have one set of goals for the family. If it's like we have now and two parents who are not really progressing at the same rate, a lot of times the family dependency court will say, well, we're just still going to go ahead with reunification with this one parent who is making progress, which sometimes means that other family member may not be allowed to be in the home if we are going to go ahead and reunify and they pose a safety threat. If it's, if they're not progressing, it kind of depends on what it is. If they're lagging behind on maybe they're not getting a job or they're not finishing their steps like they're supposed to, or they're not progressing as fast as we think they should through treatment, then we're probably going to let that family unit stay together. But if it's something where the other family member is actively using and has destructive behavior towards the family, then most likely we'll say, to the parent who's doing well, we'll still go ahead with reunification, but that other parent's not going to be able to be in the home until they get things progressing the way they should be. So we try to work with them as a family unit when we can, but like I said, if they're making progress at 2 different rates, it just kind of depends on what the issues are. So hopefully that answers that one. And then the other question was, if we're not using visitation as a sanction for relapse or noncompliance, what are some ways that we do address those issues? Usually it's a treatment response. If there's a relapse, if they're in they're in the part of the program where maybe they're coming twice a week, maybe they need to start coming 3 or 4 times a week to group. They may have more individual sessions than they had before. Sometimes he'll have the parents maybe write an essay on whatever the issue was, whether they weren't honest about something with us, or occasionally community service. But we really don't use a lot of sanctions in our family treatment court group. It delays their progress, but we don't really have specific sanctions. We try to be reward-based in our family treatment court. Anytime the parent does what they're supposed to do that week, whether it's giving the UA or attending group, they get a reward credit, which is a little plastic token, and then they can trade those in for gift cards or gas cards or food or their program fees, or there's different items they can trade their rewards in for. So we try to be really incentive-based in our family treatment court, just because we don't want to, as our commissioner usually says, you know, had family treatment court started before adult treatment court, criminal treatment courts, there probably wouldn't be sanctions, because the family dependency court doesn't work that way. You know, it's up to the parents to be motivated to fix whatever issues they were having, but they don't receive sanctions if they don't. It just kind of delays their progress. So we just try to be, like I said, incentive-based and move them through the program that way, and then our responses to relapse or noncompliance are usually treatment-based instead of sanction-based. So.
Great. Well, thank you, Julie. And we recognize there are more questions, and if we did not get to your question at this time, then we will either respond to you directly, either in the chat box or email, or we will post questions to our blog following the webinar. I did want to just highlight a couple resources as we close out today's presentation. One in which as we talked about before, there are multiple resources posted on our FGC blog, which is familydrugcourts.blogspot.com. And we've highlighted this website a few times during the presentation. So we really encourage you to go there and check it out. There's just a host of resources there available for your family drug court. So please join us again next month for our webinar. Next month we'll explore solutions together, the issue of racial and ethnic disproportionality in family drug courts. And, you know, this is a really exciting webinar for us. You're going to hear some information around some national data we have around family drug courts in this issue, and then we'll also hear from the King County, Washington, which is around Seattle, Washington, and the University of Washington. Have done some pretty exciting things around this area. So I hope you join us in August. And then on September 18th, Managing Service Need, explaining what high-risk, high-need means in family drug courts. You'll hear from Dr. Nancy Young and Dr. Doug Marlowe on that webinar, which is here to be really exciting webinar as well. It's a follow-up to the session they did at the national conference just a couple months ago. So we're excited about both of those sessions to close out this year's learning community. And I talked about this. This next month's webinar is open for registration. You can go to our website or the blog and register there for that webinar. I already talked about the blog. I always like to highlight our family drug court peer learning courses that are across the country. We will be expanding this program in the coming months and adding new courses to the program, so check back with us on it. These are courses that are performing really well and have agreed to share their practices, policies, referral forms, all those kinds of things with you all and be on the phone available to you when you have questions. your dedication, your service to children and families in your community. Julie, thanks again for your time. We really appreciated your comments, the work you're doing there in Dunklin, Missouri. And we thank you all for attending the webinar. Thanks to my staff for making this happen, and thanks to the Office of Juvenile Justice and Delinquency Prevention for their support of this program. Please complete the evaluation. Your feedback is important to us, and we'd like to hear from you. Again, thanks to you all, and have a